There have been many advances in the treatment of multiple myeloma. Literally, the paradigm of treatment has been transformed. And many of the new agents, the proteasome inhibitors, the immunomodulatory drugs, and at this year's ASCO, the monoclonal antibodies, are all tested initially in far advanced disease, relapsed refractory disease. But they've all moved into the upfront management of the newly diagnosed patient. So in terms of the initial management, whether the patient is a transplant candidate or not, in most cases, triplets or 3 drugs are utilized, combinations of novel agents, often proteasome inhibitors, immunomodulatory drugs, and steroids. So for example, lenalidomide, bortezomib, dexamethasone, or another popular triplet is bortezomib, cyclophosphamide, a traditional agent, and dexamethasone. Now, in the older non-transplant population, we use attenuated doses of these same 3 drugs as initial treatment. In terms of the novel agents that are here represented at ASCO this year, carfilzomib, the new proteasome inhibitor, again approved in advanced myeloma, has been moved to the upfront management of myeloma, this time again together with lenalidomide and dexamethasone, and has achieved very high overall and extent of response. And a very exciting new proteasome inhibitor, ixazomib, which is the next bortezomib generation drug. This is an oral proteasome inhibitor that is taken once a week and is very well tolerated. So now, in the future, we will have ixazomib, an oral proteasome inhibitor, together with lenalidomide and dexamethasone as initial treatment, an all-oral regimen. Now, the goal of therapy in the transplant patient is obviously to get the highest frequency and extent of response. In the non-transplant patient, we still, now that we have such effective drugs, have the same goals. We do need to keep in mind, however, in the elderly population especially, that there can be frailty. In other words, patients can have either comorbid diseases or they may be susceptible to more side effects from the very same agents. So we do attenuate the doses of therapy in the elderly or frail populations, or we might choose to use 2 drugs instead of 3 drugs as the initial management. And I'll just highlight, and that is going to be a very important trend for the future, the use of lenalidomide and dexamethasone as initial treatment in a continuous fashion. The first trial, the largest randomized trial in newly diagnosed elderly non-transplant candidates, has shown that lenalidomide dexamethasone continuously until progression extends progression-free survival and now even overall survival. And as a consequence of that study, we now have regulatory approval both in the United States by the FDA and also by the EMEA for use of lenalidomide dexamethasone as an initial therapy and in a continuous fashion. This will be primarily in the non-transplant population. Now, in terms of the different risk groups, we're also blessed in multiple myeloma because not only do these combinations achieve high extent and frequency of response, but especially when the proteasome inhibitors are incorporated into the initial management, whether that be bortezomib or carfilzomib or the new one coming, ixazomib, that does appear to confer benefit even in the high-risk patients, the so-called, for example, 17p deletion or p53 non-functioning multiple myeloma. So in all patients, we really want to use combination of targeted therapies. In the transplant patients, we use triplets, combination of targeted treatments. The transplant is then done, and then maintenance is incorporated into the transplant paradigm, lenalidomide in the standard risk myeloma, and in high risk myeloma, we change the maintenance to add a proteasome inhibitor. Bortezomib at the present, in the future, very likely will incorporate ixazomib. These new agents are so effective together, the novel agents in combination, that there are now randomized trials asking the question as to whether or not new drugs with or without transplant confers an outcome that's superior. In other words, maybe someday with triplets, with novel agents, or maybe someday incorporating yet another class, maybe antibodies, transplant may not be valued as much in the future. We don't know that at the present time, but at least now we know that if you incorporate novel agents into the transplant paradigm, we're getting unprecedented rates of extent of response and progression-free and overall survival.